Thank you, Ronen, dear Chairman, ladies and gentlemen. So it is a big pleasure and honor to be here, and I'm really enjoying that very much. So we are having this debate now for several years with Maurice, and I think it is very important to keep this debate alive because it makes people think. No matter where the exact truth will be, as long as it is debated, I think, in these gray zones, it is important to discuss it. So obviously, when we're talking about the timing of surgery in mitral regurgitation, there are some indications which we have accepted generally. And actually, this is Maurice's work and credit, where we know that if patients are severely symptomatic, they should be operated. Where they're mildly symptomatic or asymptomatic, their long-term survival after surgery is good. But nevertheless, the onset of symptoms should be an indication for surgery. Also, the ejection fraction is an accepted criterion for surgery. If it drops below 60% in these patients with a very reduced afterload, we consider this as being abnormal ejection fraction, and we recommend operating on these patients. Even though in the initial derivation cohort, only 11% of the patients were truly asymptomatic to assess these findings. Nevertheless, this is an accepted indication for surgery. And we have other indications that are associated with a less good long-term survival after surgery, such as atrial fibrillation or pulmonary hypertension, which are also accepted class 2A indications for surgery, where I think we all agree that we should operate on them. And then we have the debate what to do about the asymptomatic patients. There is this Mayo paper with Gigioni as the first author, where 348 patients were followed for a mean of 4 years, and there were 25 cases of sudden death observed, which is actually quite a high sudden death rate. And this already sparked the debate as to whether some of these patients should undergo earlier surgery, but reading the paper in detail, you will see that asymptomatic patients with a preserved ventricular function have a sudden death rate that is very low. It is 0.8% per year. However, patients at risk for sudden death are very symptomatic patients with a sudden death rate of 8% per year. So this is obvious. And then there's this very prominently published paper by Maurice, published in the New England Journal of Medicine, where mitral regurgitation was quantified using the PISA method, and these patients were initially managed conservatively. And you see here that patients with severe mitral regurgitation seem to have a very high mortality, close to 40% after 5 years. Actually, these are important data, but there is a limitation, namely that these patients were prospectively enrolled but did not have regular control exams at the same institution within a very specific guidance. And also patients with an ejection fraction between 50 and 60% who should undergo surgery now were included at that stage. And even patients with moderate mitral regurgitation seem to have a very poor outcome. There's a latency, but then again a drop in the mortality. So maybe it is inherent to the population that was studied or to the follow-up. Just comparing two studies from the Mayo Clinic, and this is not a critique, this is just because we should be just careful about the interpretation of the data. Paper in 2002, including majoritarily symptomatic patients, or 58% of asymptomatic patients, 20% of mildly symptomatic patients, and 20% of patients with severe symptoms, and there was a mortality of close to 20% after 5 years. And then 3 years later, purely asymptomatic patients with a mortality of more than 40% after 5 years. What happened between 2002 and 2005? So welcome to the world of Maurice. Maurice has seen this slide, so we need to put some sparkle into these debates. And obviously there's a temptation of early surgery. If I told you surgical risk is 0 and the repair rate is 100%, why not? But is that the case? There are registry studies, such as this one from Korea. Actually, it's South Korea, not North Korea, but it looks like propaganda, where if you look at the early surgical approach, it seems to convey a way of living forever. But if you read the paper in detail, you will see there's no surgical mortality for either strategy, so really excellent outcomes, better than anywhere else. Patients lost to follow-up, 17 of them, apparently all in the early surgical group. 3 cases of death are not accounted for because they're not related to the heart, but actually there were strokes and infection. We do not know if they're maybe related to surgery. And then the events in the conventional group included heart failure as a trigger for surgery in 22 patients. 5 patients died of congestive heart failure, but they had refused surgery, and there was 1 sudden death in a patient who had become symptomatic previously. So I think there's no conclusive answer from that study. And then there's the MIDA series, a very prolific study group, including now 6 centers, including the Mayo Clinic, that has included patients over a time span of 24 years from 1980 to 2004. And in that time span, 1,000 patients did not have a class 1 indication for surgery. All of these patients had Flail leaflets. Again, if you look at this event-free survival or survival curve, early surgery seems to be associated with a substantially better outcome than medical management. But again, it's a retrospective registry. And if you look at the propensity score matched cohort, the difference in outcome already becomes smaller. And also, 19% of the patients in the medical management group had classes 2 indication for surgery, namely atrial fibrillation or pulmonary hypertension. And watchful waiting was defined as each patient had follow-up visits with a physician within each participating center, which is fine, but then it adds or elsewhere. So basically it is watchful waiting or anything else. And I think watchful waiting is a very strict follow-up approach. And then the cutoff between early surgery and medical management is quite arbitrary. Here it was defined as within 3 months of diagnosis. And there are many centers who actually take 3 months just from the workup until surgery can be completed. So let's look at the details. The methodology of mitral regurgitant quantification in the MIDA study. So it was quantified on a scale from 1 to 4 by Doppler echo according to the American Society of Echo criteria. And this is the reference number 18. And this is very interesting because these echo criteria were published in 2003, but MIDA started in 1980. So it is a very visionary study. And also, if you read these echo criteria, they actually recommend grading according to mild, moderate, and severe. So only 3 grades and not 4. And if you look at the first Doppler, color Doppler images used for the quantification of mitral regurgitation, this is what has been published. And obviously, it is interesting, it's nice pictures, but hard to interpret. And this is the initial publication that was published in 1984, so 4 years after MIDA started. And as you know, color Doppler became widely available after that. Just looking at the mass, 6 centers, 24 years, 1,000 asymptomatic patients. That makes 1 patient per center every 2 months. Either it is a very infrequent problem or it is related to the way we do our studies. And the MIDA registry is very prolific. As I've told you, there are many publications coming out of that registry. In the meantime, there have been other studies added. But basically, with this paper in 2013, we had 5 centers who had included 860 patients between 1980 and 2004. And obviously, there's one registry. And these are very nice paintings. It's the haystack painting by Monet. And you can look at it as many times as you want. You can look at it one season and the next season, but you will still see a haystack. So it will not be surprising that if you publish from the same registry, that you will not see any substantial differences in the interpretation. And then there's a very nice saying that states knowledge is knowing a tomato is a fruit and wisdom is not putting it into a fruit salad. And actually, I do not know what has happened here. Maybe Maurice will tell us. Between this paper and the JAMA paper published also in 2013, there was a Belgian center that joined MIDA, but suddenly the numbers of patients just jumped. They more than doubled, and I do not know how to find an explanation for that. And there are issues with mitral regurgitation quantification. Even if we try to use quantitative methods, substantial, and we know this by the very nice work by Vienna and colleagues, substantial agreement is only given in approximately 50% of the cases. And also substantial disagreement, therefore, is present in 50% of the cases. And this is a very intriguing paper that was just published in JACC this year, where patients who were actually referred to mitral valve surgery had their mitral regurgitant severity reassessed by core labs. And you see that the core lab actually only said only 56% of the patients had true severe mitral regurgitation by echo. And if this was compared to MRI, only 15% had severe mitral regurgitation by MRI. And in terms of ventricular response after mitral surgery, negative remodeling was most prominent in patients who had severe mitral regurgitation by MRI. I do not want to say, and I think that this study does not allow us to tell us that MRI is better in quantifying mitral regurgitant severity, but it highlights the fact that mitral regurgitant severity may be tricky and is not always unequivocal. And if we operate on asymptomatic patients, we may operate on patients who will have moderate mitral regurgitation. They will obviously do well after surgery. If we repair a valve, this is obviously what we want to achieve, successful mitral valve repair. But the true data state that although there are improvements, many patients still receive a valve replacement, probably more than 30% nowadays. And if you look at data from the United States, there are obviously surgeons who have a very large experience here, who have a very high repair rate, and these are surgeons who operate more than 50 cases a year. In the US, apparently only 3 surgeons do more than 100 mitral valve procedures per year. And strikingly, the median number of mitral surgeries is of only 5, meaning that surgeons do 5 surgeries, but they still would propose doing surgery in asymptomatic patients. And probably it takes 50 cases for a surgeon to achieve a repair rate of 80%. And the individual surgeon experience is also important. The number of severe complications and overall mortality will go down with the absolute number of surgeries. And you see here that there's a learning curve that takes probably more than 300 mitral valve procedures. And some patients will need a re-repair procedure at a rate of 1% per year. So it is not that we fix the problem forever. There are issues, and other patients will have recurrent mitral regurgitation who will not yet be operated because the threshold for reoperation is higher, or because mitral regurgitation is not that severe, but still present to a more than moderate degree. And on the other hand, the question is, can we actually wait for surgery in asymptomatic patients with severe mitral regurgitation? And when we followed our patients very closely according to this watchful waiting strategy, the overall survival was comparable to an age and gender-matched control population. However, 50% of our patients needed surgery within the follow-up period of 8 years. So it also means that events may occur at any time, and these patients really need close follow-up. So watchful waiting is actually an aggressive strategy, and it also requires being able to monitor these patients. And if we're not monitoring, we may lose the patients at these time points, and then their outcome may be substantially worse. And while 2/3 of patients will have symptoms as the indication for surgery, 1/3 of the patients will present with asymptomatic signs of ventricular dysfunction, atrial fibrillation, or pulmonary hypertension. The majority of the patients who will also present with left ventricular dysfunction or atrial fibrillation will be symptomatic. Nevertheless, 1/3 will not be. Therefore, watchful waiting is a strict approach that requires 6 monthly control intervals including echo, clinical assessment, and an EKG, instruction of the patient to promptly report the onset of symptoms, and referral to surgery without delay once the criteria for surgery are being reached. Are these series that we have looked at substantially different? It depends on the way we look at them. Obviously, the New England paper by MAURICE included slightly older patients, 61 years of age. Also, the MIDA series includes older patients. In our series, patients were slightly younger with an age of 55, but the Korean series had an even lower age with 50 years. The left ventricular diameters are slightly larger in the New England paper with 37 millimeters, but relatively comparable between the MIDA studies and our series. And there are additional ways of risk stratify, looking at left atrial size. I think it can be a helpful determinant in intermediate decision points where we know that patients with large left atria are likely to develop symptoms in the near future. And just to come back to the MIDA series, even in the MIDA series, it was shown that as long as the endsystolic diameter is below 40 millimeters, there was no excess mortality with medical management. It was only after that in the MIDA series, the authors described an increased risk of overall mortality with conservative management. And when it comes to restoration of life expectancy, the question is, do we need to operate on truly asymptomatic patients? And this is, again, the Mayo Clinic experience, where life expectancy can be restored with mitral repair, and it can be restored for different age groups. And if you look at the series here, it included 57% of patients with severe symptoms, 40% of patients were in atrial fibrillation, and ejection fraction was not supranormal. It was 58 plus minus 13%. And even the Koreans actually had a follow-up paper what included data from a second series, and this time they tried to get the endpoints right, and this is what actually the outcome in terms of overall survival is. There were some differences in cardiovascular events, but actually both strategies, the conventional strategy and the surgical strategy, had the same overall survival after 12 years. And obviously, if we're talking about this debate, probably one structure that is required for good follow-up and for good watchful waiting strategy is a heart valve clinic where patients with valve disease can be followed in an appropriate setting. And when we look at the guidelines, probably the indication that was put forward by the American guidelines to state that mitral repair is reasonable in asymptomatic patients when the likelihood of successful and durable repair without residual MR is more than 95% with an expected mortality rate of less than 1% as a class 2A indication could be acceptable, but this means that it should only be done in high-volume centers and only in the hands of these very few expert surgeons. The problem is that the way it is formulated, it will open the door and everyone will feel, or many surgeons who do not have this experience will also feel that they should operate on asymptomatic surgeons. Remember that the median number of surgeries in the US is 5, and this is the problem. I thank you for your attention.
Thank you, Raphael, for this very exciting presentations. And I think for the sake of the debate, we'll let now Dr. Serrano make his presentation, and we invite Dr. Serrano is from the Mayo Clinic at Rochester, Minnesota. He advocates early mitral valve surgery as the preferred approach, and we'll have questions to both